Welcome to our comprehensive review of ostomy care and diversion management. Today, we'll cover key clinical factors from preoperative visits to long-term complication management. Starting with preoperative factors, goals can be curative or palliative. We often see Crohn's disease presenting with abdominal cramping, diarrhea, and rectovaginal fistulas. In neonates, look for anorectal malformations or signs like intestinal pneumatosis on X-ray, which suggests serious issues like NEC in premature births. For bladder cancer, early symptoms often include intermittent microscopic hematuria. Advanced cases invading the bladder wall may require a cystectomy and an Indiana pouch. Stoma assessment is critical. We evaluate the mucocutaneous junction, lumen, and mucosa. An ideal stoma protrudes about 2 centimeters and is round and centered. Site selection must be within the patient's line of vision for independence. Remember, for morbidly obese patients, we often mark the site higher on the abdomen. When managing soft abdomens with good protrusion, flexible pouching systems are preferred. Use the PLI-SSIT model to provide specific suggestions for intimacy concerns. Protecting peristomal skin is vital. Cleanse with water only, and for fungal infections like candidiasis, use antifungal powder rather than creams. Alert! If a new stoma becomes necrotic below the fascia, there's immediate concern for the superior mesenteric artery. This requires urgent surgical consultation. Descending colostomies typically produce formed stool. Common indications include perforated diverticulitis or cancers requiring an APR or LAR procedure. Patients with a Hartmann's pouch should expect to pass mucus rectally. If they wish to start irrigation, advise waiting until after any chemotherapy is complete. The ileal pouch anal anastomosis, or IPAA, is common for ulcerative colitis. Loop ileostomies used here often have higher output than terminal end ileostomies. Villi in the small bowel are key for nutrient absorption. If a patient has no output with cramping and nausea, they must go to the ER for potential food blockage. Watch for pyoderma gangrenosum, a painful, full-thickness ulcer with violaceous edges. For hypergranulation tissue, silver nitrate is the first-line intervention. For ileoconduits, use extended wear barriers to prevent wash away. A pink edematous stoma with stent output is a normal finding in the early post-op phase. Prevent otitis and odor by encouraging 6 to 8 glasses of water daily. Use pouching systems with anti-reflux valves to reduce the risk of retrograde infection. Continent diversions like the Indiana pouch involve intubating the stoma after healing. Remember, finding mucus shreds in the urine is considered normal for these pouches. After an IPAA takedown, perianal skincare must start immediately. Patients can thicken their stool by eating foods like bananas, pasta, cheese, and rice. Fistulas often stem from anastomotic leaks. Surgical closure is usually required if the 24-hour output consistently exceeds 1,200 milliliters. When pouching a fistula, select systems based on the volume and odor of the effluent. A sizable cut-to-fit skin barrier is essential for a secure seal. Percutaneous tubes require careful stabilization to prevent dermatitis. While PEG tubes don't have balloons, other types do, and their water levels should be checked weekly. If a gastrostomy tube is clogged, use a mixture of crushed pancreatic enzymes and sodium bicarbonate in warm water to clear the obstruction safely. Independence is the goal. For patients with poor vision or arthritis, make teaching accommodations and refer to occupational therapy for assistance with closure devices. In pediatrics, we expect children to begin managing their own ostomy care by school age. Families of babies with VACTERL will need specialized teaching on colostomy and anal dilations. If a stoma lengthens and begins to bleed, consider it a prolapse. Measuring for a hernia belt with a prolapse support device is a key clinical intervention. Patients with an orthotopic neobladder must learn to empty based on a sensation of pelvic fullness. They often benefit significantly from postoperative Kegel exercises. When investigating a leaking pouch, always assess the abdominal contour and muscle tone in various positions. Teach patients to watch for itching or burning as early signs. Clinical clues are key. Urine shooting out often indicates stoma stenosis. For odor concerns without infection, investigate dietary triggers, like fish in Indiana pouch patients. From site selection to managing complex fistulas, the ostomy nurse specialist plays a pivotal role. Empowering our patients through education ensures the best possible outcomes.